It's my great pleasure to introduce Professor Ajay Maker.
Thank you.
Thank you.
Fantastic. Well, what an absolute honor to be here today, to have the opportunity to travel across the world, to make new friends, and to make new collaborations so that we can advance our field, as Magnus said, to put ourselves out of business, because no one will be happier about not having to do large cancer operations than everyone sitting in this room. I am very appreciative to Glenn Bonney, Jimmy So, the organizing committee, and everyone else for really pulling off a fantastic meeting. Well, I've been charged today with discussing much of what Dr. Bonney has very nicely introduced, which is what is happening in our bodies that is making the liver a unique environment for metastasis to set up shop. 1 in 100,000 cells that reach the liver will actually live and metastasize. 1 in 100,000. Let's think about that for a moment. If we take the largest venue in Singapore that I could find, which is the National Stadium, and you filled it to capacity for a soccer game, football game, I guess we'll call it here. And then that's not enough. You have to then go to a K-pop concert the next night and fill it again. And that's about 100,000. And one lone individual would be that 1 in 100,000. That would be that one cell that has the ability to survive. And yet, as rare as it seems that this is, about 5% of all cancers will present with synchronous liver metastasis. So something doesn't match. What's happening that's unique? If we look at colorectal cancer, the most used example, 50% will present with synchronous liver metastasis. Other GI cancers like pancreatic and gastric cancer, they will also present with 30-40% of liver metastasis. But this isn't exclusive to GI cancers. Breast cancer, neuroendocrine cancer, very common examples where 20 to 40% of these cancers will eventually metastasize to the liver. How is this happening despite all the percentages that we just talked about? And it's happening in a question that has been asked for over 100 years. And it was presented by Prof Ajay as the seed and the soil. But we've come further, haven't we? What is the seed? The seed is that tumor cell. We now know that that tumor cell, that seed, has to have pro-inflammatory factors such as TNF-alpha. There have to be expression of very specific adhesion molecules, selectins and cadherins, to allow that cancer cell to actually leave. And then that cancer cell has to have a passport and a visa to know where it's going and then be allowed in to the country it's going to. And the most common example for the liver for GI cancer would be CXCR4. And so that cancer cell has to leave the tumor. This is actual visualization of the tumor cell trying to do so, and intravasate. And by intravasate, meaning get into the bloodstream. Now, once it's actually in the circulation, that cancer cell will have a gamut of obstacles that it must be overcome. Just by being in the osmotic environment without nutrition, many of them will not make it. The sheer forces of bouncing across non-laminar flow will get rid of many more. Now, we do have natural immune system that is going to try and fight these, and so our NK cells and other immune modulators will take care of many more. But for the rare cell that gets to marginate and then leave the vasculature and enter into the soil, that is at 1 in 100,000. But it still needs to survive once it gets there. And so we've talked about the seed. What is unique about the soil? Well, the liver is a unique environment. It drains the entire portal blood flow of the GI tract. So yes, that is unique. And what else is unique? Well, the cells have complete and unfettered access to the hepatocytes because of the space of Dis and the sinusoidal anatomy. There doesn't have to be complete margination and extravasation to reach the soil of the liver. It is bathed. The cancer cells can actually be bathed in the sinusoidal environment. And this is where the Seed and Soil 2.0 comes in, which is what I'd referred to in the talk a few months ago as the sun and the water. And what that means is that there's more than just the seed in the soil. The liver is getting all of the portal blood flow, which means it's also getting access to all of the microbes, antigens, bacteria, LPS, and everything else that's draining the entire GI tract and emptying into the liver. And thus, evolutionarily, the liver has set itself up as an immune-tolerant organ in order for us to even survive. And so if it's an immune-tolerant organism to all these antigens, it's going to be immune-tolerant to many cancers as well. And this creates what is referred to as the pro-metastatic niche. And this is really what we're going to talk about most in our discussion today, which is what are the sun and the water? Well, at the end of the day, we're at a surgical meeting. Who cares why they form? We can cut them out. That's what we talk about at our surgical meetings. And Dr. Bonnie showed us nicely all the different machinations that we can do with two-step procedures, parenchymal sparing surgery, et cetera. And if we can't cut it out, we have all these brand new immunotherapies. Let's just use them. Well, if we do cut them out, we can actually increase median survival to about 5 years for resectable, highly selected patients with colorectal liver metastasis. So there is a reason to believe in our surgical prowess and our decision making. And 20% of those patients will actually be cured, meaning no recurrence after 10 years from surgical resection alone. And I'm as guilty as anyone else for presenting these at our meetings, bilateral metastasis, different ways of approaching these. But the bottom line is surgery is often enough. And Dr. Bonnie just showed you a beautiful quote by Blake Cady. And the rest of that quote was the technical aspects are the princes and paupers of the realm that try to overthrow the king and the queen and often to no long-term avail, because these are the scans that we run into where really surgery is not going to be enough. And why is surgery not enough? It's not enough because that pro-metastatic machinery is already in action before that primary tumor even becomes evident. And we know this for some beautiful studies in pancreatic cancer from Michael Buzio's group, where the pancreatic cells are already circulating 20 years before we know that that primary is in place. Now, we're getting much better at figuring that out. We now can measure circulating tumor, DNA, exosomes, CTCs, et cetera, and this is obviously an area of hot research. But we knew this even before we had these techniques. And when we talk about pancreatic cancer in particular, this is a beautiful model that is a preclinical model that showed that the liver is universally seeded with pancreatic cancer before that pancreatic cancer even forms as the primary tumor. And so that machinery is already in place, and by the time they come to us, we are far behind the 8 ball. Now, how is that happening? It's happening because the primary tumor itself is setting up a pre-metastatic niche in the liver. What do I mean by that? Well, what I mean by that is that the cancer itself, in this case we'll use the example of a pancreatic cancer, it is actually shedding microparticles that are changing the environment within the liver before the cells even get there. The Kupffer cells, which are the unique macrophages in the liver, will then secrete pro-inflammatory factors. Stellate cells become activated. And this deposes a new extracellular matrix. And this fibronectin is actually railroad tracks that are being placed for cancer cells to take hold and move throughout the liver within this niche that now is accepting in the soil of the liver. This fibronectin also binds suppressive immune cells, which we'll talk more about in a moment, called MDSCs. And those eventually will support a suppressive immune machinery made of suppressive or regulatory T cells, and that inhibits natural killer cells and cytotoxic T lymphocytes. This is the sun and the water that is being created. Now, there's 4 phases once the tumor cell actually makes it into the liver. The first is the microvascular phase, which we touched upon already, which is extravasating into what becomes the pre-angiogenic phase, which is when those cells enter into the space of DIS. Again, that unfettered pool where cancer cells are exposed to hepatocytes and to the tumor microenvironment. And this is where that extracellular matrix and different angiogenic factors like VEGF become secreted, because that cancer cell, that 1 in 100,000 again, cannot live without a good blood supply and without establishing nutrition. which leads to the angiogenic phase. Now, the angiogenic phase is really going to determine whether that cell can persist. Interestingly, the growth pattern of the tumor itself will determine what that angiogenic phase will be. Now, if we use the example of colorectal liver metastasis, we can talk about 3 different growth patterns and how these are going to impact the angiogenic phase. This is the desmoplastic phase. And in the desmoplastic type, what you can see here is that there's actually an inflammatory border between the tumor itself and the hepatocytes. And surgically, we see these. When we remove these, it almost feels like an enucleation sometimes, right? And we visually can see it, but this is a histologic diagnosis. Then there's also something called the replacement growth pattern. This is when the tumor itself starts to grow into the surrounding hepatocytes and interdigitates with them. Not surprisingly, it's a different biology of disease. And the third described type of colorectal liver metastasis is the pushing pattern. These are the most difficult for us surgically because the tumor itself is really just pushing everything out of its way and going wherever it wants to go. And within liver metastasis, these have the worst survival. But it's unique how these impact how they get their blood supply, because the angiogenic phase itself will determine the biology of these tumors. So if we look at these examples, that replacement pattern where the tumor itself is growing into the hepatocytes that already exist, it co-opts the blood supply from our natural liver. It doesn't have to do much work other than to steal the blood from what already exists. Now, as one can imagine, these are not going to be very sensitive to anti-angiogenic chemotherapies like bevacizumab, which is true in a subset of colorectal liver metastasis, but is true in the majority of breast cancer metastasis to the liver. On the other hand, the desmoplastic subtype that we talked about that creates that fibrous border around it, it now has to create its own blood supply because it cannot co-opt it from the surrounding liver. And as a result, as one would imagine, it is actually exquisitely sensitive to anti-angiogenic chemotherapies or biologic therapies like bevacizumab. And so we can see that the phase determines the biology of the tumor, which then leads us to the 4th phase of once that tumor is there, trying to set up a blood supply, trying to survive. And that's the growth phase itself, where it starts to interact with the immune tumor microenvironment, which we'll talk about for the rest of this discussion. So there is this interaction between all these immune modulators. And as we mentioned before, let's use some of our new immunotherapies. Well, it turns out that for the majority of liver metastasis, because of this unique environment set up in the liver, the current checkpoint blockade modalities that are available for many other malignancies have no activity against the majority of liver metastasis. And if we use the example of colorectal liver metastasis, the initial trials with anti-CTLA-4 antibodies showed no responses. And years later, we became very excited because PD-1, PD-L1 was becoming FDA approved, and this was the landmark New England Journal of Medicine trial. And if you look at who actually responded in that trial, none of them with metastatic colorectal cancer to the liver or liver metastasis were responding. And so we can't use our traditional checkpoint blockade immunotherapies. Why? What's unique? What about for tumor types that are exquisitely checkpoint blockade sensitive, like melanoma, like certain types of lung cancers, like renal cell cancer? These should be very responsive, and yet, if there are liver metastasis from these primary pathologies, those patients have a decreased response rate to checkpoint blockade immunotherapy, and they have decreased overall survival. And you can see that in this beautiful set of studies that were put forward by Wei-Ping Zhou and his group last year from Michigan. How and why? You go one step further, and it turns out that the circulating anti-tumor T cells are less in patients that have liver metastasis. Let's think about that for a second. Why would that be the case? You have T cells that recognize tumor antigens and are circulating. But if you have a liver metastasis, there are less of them. The theory that's put forward in this set of studies is that the tumors themselves in the liver can actually siphon off the anti-tumor T cells. And it's happening through a fast ligand interaction of the macrophages that exist in this liver, this unique soil, this unique tumor microenvironment of the liver that can actually cause apoptosis of the anti-tumor T cells. And this is shown in this beautiful set of studies. Well, what does that leave? If you take away all of our anti-tumor mechanisms that exist in our immune system, what you're left with is an immune desert. An immune desert taken over by T regulatory cells, tumor-inducing macrophages, and a subset of cells called myeloid-derived suppressor cells. And if that's all you're left with, then the tumors can actually grow. Let's talk for a moment about the T regulatory cell subtype, because there's a beautiful study that came out from our group last year that said, what if we can get rid of the T regulatory cells and then give checkpoint blockade in an otherwise sensitive malignancy? Will that change anything? And in a preclinical model, it in fact does. If you get rid of all the T regulatory cells, you can take a formerly checkpoint blockade resistant situation with liver metastasis and now even make those liver metastases responsive to the checkpoint blockade. So there's some hints that we can manipulate this tumor microenvironment to our advantage. Well, starting about 10 to 15 years ago, we asked a very basic question in our lab, which is there a reason to believe that immunotherapy has any practical role in colorectal liver metastasis? With all the problems that we saw in the immune tolerance of the liver and all the data that I showed you that's new since then, it begs the question. And so we looked at our last 100 resected colorectal liver metastasis, and we stained them very simply to start with for markers of T cell infiltration, CD3, CD4, CD8, CD25, FOXP3, etc. And what we found was that if you had more T cell infiltration into the liver metastasis, you had improved recurrence-free survival and improved overall survival after resection. Okay, so there's a hint, and it makes sense. If tumors are being recognized by our immune system, survival can be improved. When we then dissected out what was happening at the gene level within these resected liver metastasis, we found that if there was overexpression of a tumor necrosis factor superfamily cytokine, which we'll call LIGHT, which is just much easier to say than tumor necrosis factor superfamily 14. So if you have increased expression of LIGHT, that was the number one association with improved recurrence and overall free survival. So what did we do? We went back to the lab and created a microsatellite stable syngeneic colorectal cancer cell line that we could inducibly overexpress LIGHT. And if we overexpress LIGHT in vivo, we can draw T cells into those tumors. Every one of these green dots here is a T cell that's being driven in. And you can get 2, 3, 4, even 6 times more T cells trafficking into that tumor by changing the tumor immune microenvironment by overexpressing an immunostimulatory cytokine. So we had discovered this mechanism, and we had studied it further and proved that this was the case. And we thought we could traffic more T cells in the tumor microenvironment. We then wondered whether we could further activate these tumor-infiltrating lymphocytes by using checkpoint blockade. And this is the proverbial 1-2 punch that we were hoping that we could accomplish. And so we did a randomized controlled preclinical trial in a model of colorectal liver metastasis where it's an isolated colorectal liver metastasis model. In the control animals that received no treatments at all, the liver becomes completely replaced by tumor. And you can see that even on the ultrasounds that we would do on these animals every other day. If we gave standard of care checkpoint blockade, whether it was with anti-CTLA-4 or an anti-PD-1, I'll show for the purposes here, our anti-CTLA-4, it's a partial response. Not surprising. It's microsatellite stable. This is not, as 95% of liver metastases are, it's not traditionally checkpoint blockade sensitive, and so this is what would be expected. Now, what if we use our immunotherapy, which is increasing expression of LIGHT? As we had published a few years earlier in cancer research, we saw a partial response, sometimes less, sometimes more, and we saw T cells driving into these tumors. But we weren't seeing a lot of complete responses. And if you can't cure cancer in an animal, how can you cure cancer in a patient, right? And so when we combined these two treatments together, we began to see CRs. And we didn't believe it, so we repeated this. We repeated this 5 times. and we kept getting complete responses. And this is one of the most exciting things we saw, and now it was the onus on us to figure out how this was happening. So, unsurprisingly, combination treatment excites the tumor-infiltrating lymphocytes. This is data from CyTOF, which is a way of doing flow cytometry on tumor-infiltrating lymphocytes. And what I've circled here is that the exciting factors around T cells were clearly evident with monotherapy and with combination treatment. Things like granzyme B, which is a cytotoxic T lymphocyte factor, or interferon gamma, which is an excitatory marker, an activation marker for T cells. And if we looked at the subsets of T cells, specifically those cytotoxic T lymphocytes, we saw the same phenotype perpetuated. So we could actually activate those T cells in the tumor microenvironment. But the proverbial horse can only be whipped so hard before that horse fails to run. And that's what's called exhaustion. That's why most of our immunotherapies work for a period of time and then there's resistance. The T cells get exhausted. Could we decrease that exhaustion? And what we found was that the combination treatment got rid of all of these exhaustion markers, which you can see, CTLA4, LAG3, TIGIT, etc., overall in the T cell subset, but also in the cytotoxic T cells. So now we could activate the T cells and get rid of the exhaustion. And so if we go back to our immune desert, potentially we can take away the impact of those suppressive features, manipulate the sun and the water that are adding to the seed in the soil. And so in this last set of experiments I'll share with you, this is a UMAP, which is a single-cell RNA-seq analysis and a way of looking at specific T cell subsets in the tumor immune microenvironment. So let's look at this subset. These are the MDSCs. In the wild-type control animals that receive absolutely no treatment for their colorectal liver metastasis, it is full of MDSCs. However, if they get either monotherapy or combination treatment, that aspect of the immune desert can be then dealt with. But what about this population? This population is the tumor-promoting macrophages. They don't exist in the control animal. Okay? However, if you start to give immunotherapy, either checkpoint blockade or our immunostimulatory cytokine light, now all of a sudden we're not only activating the T cells, we're also activating the anti-tumor macrophages, these M2 macrophages. And this is a huge problem because this is supporting the immune desert. But if you combine those two immunotherapies, you can now remove that inhibitory feature. So this was incredibly exciting because in essence, what we're trying to do is take cold tumors and now make them hot. And potentially, by manipulating the tumor microenvironment with new immunotherapies, we can actually accomplish this. Now, what we want to do is get these into our patients. And so we've designed some very nice oncoviruses and other ways of selectively delivering light and other immunotherapies into the tumor microenvironment. But what if we could do it regionally? What if we could deliver it directly into the liver? Now, what's beautiful about liver metastasis from a GI origin is it all comes, as we mentioned, through the portal vein, but it's getting its nutrition and blood supply, as most liver metastases do, through the arterial flow. So if we could access that arterial flow, we could then introduce regionally anything that we wanted to. And so we've started doing this. This is not a new technology, but it has lost excitement over the era of full FOX, full Fury, full FOXIRI, anti-PD-1, anti-CTLA4, but it's time to revisit it. And so when I moved to San Francisco, we revitalized the hepatic artery infusion pump program. And this was the first pump that we put in about a year and a half ago. And we're now putting these in about 1 or 2 a month. And what you can see is a catheter going into the GDA, which has complete access into the arterial anatomy of the liver. So you can see in this particular example, there's a liver metastasis that's been removed in segment 4, some metastasis that have been removed in the left lateral segment. And I'll now inject ICG into this catheter. And within seconds, you will see that through that catheter, you have access to the entire perfusion of the liver and only the liver. So an incredibly cool way, in my opinion, of accessing the liver for anything that we want to get in there. And so the current trials and studies that we are writing for grants as we speak are ways of manipulating the immune system through this avenue. We just put the first patient on a trial that's being run by my colleague Chloe Atreya at UCSF, where we're using an anti-TGF-beta combined with an anti-PD-1 antibody in patients with resected liver metastasis. And we hope in the next generation of this to be able to introduce some of these agents in a regional fashion rather than just systemic. I put this here for now my good friend Sridhar, who's the program director for the residents. For the residents, you are in the best position possible to decide what questions we need to be asking to help these patients. Charles Huggins is a surgeon, and in his Nobel Prize-winning speech, he said, "With blood on my hands I can discover, seated at my desk I have no chance." And so you hold the keys to helping us figure out how to do this in the next generation. And surgeons themselves and surgical oncologists are uniquely important. We are losing surgical oncologists from translational medicine, at least in the States. And it's exciting to be here to make collaborations with other like-minded individuals to see how we can move this field forward. So in conclusion, the formation and progression of liver metastasis involves not just understanding the seed and the soil, but also the sun and the water, which is this tumor immune microenvironment. And this interaction between the immune system and liver metastasis is determining the current and the future of therapeutic strategies. I'm indebted to all the individuals that did much of the data that I showed here today. Our group in the lab above is including our new postdoc that's come over from Italy, Dr. Polini. And this is our group of surgical oncology, our division of surgical oncology at UCSF. It's just a fantastic group of surgeons and scientists that I had the great privilege of working with. And of course, none of this can happen without our grant funding. I thank you for your very kind attention. I look forward to speaking with everyone more here during this wonderful time in Singapore. And please reach out to me otherwise at any time. Thank you. Thank you so much. Thank you,
Glenn. We have time for maybe a couple of questions. So please do come to the mic. And
well, if nobody asks, thank you very much, Professor Ajay. Although I'm no liver surgeon, but I enjoy your wonderful talk very much and your nice example of sun and water. May I ask a question? You have shown the tumor microenvironment, how this has been changed by the tumor cells. I think this change can be bidirectional, I mean vice versa. So you bring a seed from Singapore, you grow it in the US, it may not grow the same plant. So my question is, when a colorectal cancer started to migrate to the liver, and in that environment, do you think they will change in some way genetically and behaviorally? Therefore, what is the implication in the treatment?
Thank you. So if I understand your question correctly, it's that is the genetic makeup of the liver metastasis different than the genetic makeup of the primary tumor?
Yes.
Is that?
Yeah, is it identical? Will that be changed by the different environment,
Yeah, I think it's a very good question. I think the answer is more in the epigenetics than the genetics of it. Because we do know that if you look at the primary tumor, what goes to the lymph nodes and then what actually goes to the liver, there is a clonality. I left out some other slides. There are different pathways. There's clonal metastasis and there's non-clonal metastasis. Both exist. But let's say it is a clonal metastasis. It's going to act differently based on how that seed, soil, sun, and water impact expression of the genes within that. So in that sense, I think the RNA expression is far more important than what's happening at the DNA level. And that is open now to beautiful studies that are being done on microRNA expression, different impact of the interactions of the immune cells with the primary tumors and how that's changing surface expression of different pro-inflammatory markers. So I agree with you 100% that something is happening once it reaches the liver that's making that cell different than what it existed in the primary tumor.
Thank you. We open to the floor, please.
Prof Ajay, thank you for your excellent talk. And you've shown the result of a combo treatment with the light and also either CTLA-4 or PD-1. One thing that I always ask myself with combo treatment is how much of the combo is enough? Is 2 is probably better than 1, but is it sufficient? Or decide whether it's sufficient, or do we go up to 3 or 5 or even more treatment that we required?
Yeah, it's a great question. So what I showed you here was some of our unpublished data. Maybe on the 15-hour flight back, I'll actually be able to finish writing the paper that needs to get done. I left out that we did monotherapy and we did combination therapy. Why? Very provocative data that began in melanoma, which is a combination of anti-CTLA-4 plus anti-PD-1 with a greater response rate in those patients. And now that's actually standard of care, first-line treatment, right, for extensively metastatic melanoma. What we found in this model was that there was no synergy between combining the 2 checkpoint blockade immunotherapies, meaning anti-PD-1 plus anti-CTLA-4. There was not an improved response rate. There was not an improvement in activation or exhaustion. And so, at least in this model, we saw that the advantage was combining more anti-CTLA-4 than actually anti-PD-1 with the pro-inflammatory cytokine.
Okay, thank you.
Okay, thank you very much for that questions, and big round of applause for Professor McAjay.